Hello, folks. Thanks for joining us on Head Inside Mental Health, featuring conversations about mental health and substance use treatment with experts, advocates, and professionals from around the country sharing their thoughts and insights on the world of behavioral healthcare. Broadcasting on WPVM 1037, the voice of Asheville, independent commercial-free radio. I am Todd Weatherly, your host, therapeutic consultant, and behavioral health expert. We have a star-studded guest list on the show today, which I'm excited about. It is my pleasure to welcome back to the show Dr. Ross Ellenhorn, founder of Ellenhorn Assertive Community Treatment and Community Integration Programs in LA, New York, and Boston, as well as founding partner of Accord, a holistic treatment program embracing metabolic psychiatry, bridging the gap between mental and physical well-being left out by traditional psychiatric med management, and author of a few books, How We Change. I uploaded. I got my book set done. I need signatures from you, Dr. Ross. And more recently, Purple Crayons. The Art of Drawing Life. Which, when he told me about this book, I thought he was actually the Purple Crayon kids book author, and was about to be even more impressed. But this is a lot about how people can draw a life for themselves, especially if they're suffering from mental and emotional conditions. So we also welcome back to the show Sarah Summey, doctoral candidate in public health administration at the University of Texas and executive director of the Lakewood Center, a therapeutic community designed for long-term care, enhancing the lives of adults with serious mental illness. Along with her, we welcome to the show Lakewood Center Medical Director and psychiatrist Dr. John Stevens, leader in personalized mental health care, board certified in child and adolescent and adult psychiatry and obesity medicine. Sarah and Dr. Ross, welcome back to the show. Dr. Stevens, thanks for joining us.
Thanks, Todd.
Absolutely.
I do have to say, so my mother doesn't disown me, it's the University of Tennessee, the original UT.
Yeah, right. Not far from
She'll
me.
disown me.
Right. Right. Those UT folks, they're pretty serious about their school. That's some school pride out there.
Yeah. Thanks for having us, Todd. We're happy to be here.
You're most welcome. And Dr. John, we're getting to know each other, and but you've worked with some of the clients that we've had down there at the Lakewood Center. I've known Dr. Ellenhorn here for quite a while, and Sarah for quite a while. She's actually from our area, and I'm just looking at everything. I thought there's kind of three places that we could spend time talking about. One is part of the new program that Ross helped start recently, which is the metabolic psychiatry, and kind of where traditional psychiatry leaves out the metabolics, the diet, the things that you're putting into body and what kind of impact they have on the brain, because a lot of our psychiatry is driven ultimately by emergency psychiatry. You go in and they dump you full of meds and they stabilize you enough, and then you go out and you feel like a space cadet, and it's no wonder people go off their meds a lot, because they feel weird and they don't like it, and it comes with a lot of metabolic and gut problems and attention problems, sleep problems, all the other things. And so some of this approach, especially for people, and this goes into the category for you, Dr. Stevens and Sarah, is the long-term care aspect. It's one thing to get a person into emergency care and get them out on the street and get them so that they're not, having a psychotic break or not endanger themselves or others and those kinds of things. It's a pretty low bar in terms of a person's care. And then what do they do after that? As therapeutic consultants, we get involved a lot at a time when the emergency care is needed, the residential care is needed, and getting them through kind of this, let's figure out what is the ideal medication level, what are these places that we get to, and what is it going to look like long term. And then, ideally, we'll either find a program like Sarah's, or we'll find a program like Dr. Ellenhorn's, and where they can receive a community approach to care. So that's the other piece, is like long-term care, but a community approaches to care. Community integration for people as a treatment modality is this kind of the thrust of the therapeutic approach, is to have connection with others. And so something that the front end of mental health care and a lot of community mental health care misses, or if they've designed ACT teams, like, Ellenhorn is an ACT team,
Mhm.
The ACT teams are not managed very well. So, what is it? I think the big question, and I pose it to all of you, is like, where did you start and how did you come to realize that models of care that you're now engaged in are a better way to go? Like, where did the shift happen for you guys? You want to start, Dr. Ross? I know that ACT team is a big ACT team
Yeah.
is a big thing. You're kind of one of the pioneers of an ACT team from very, very long ago. So why don't you hit that first and then we'll work our way.
Yeah, I mean, I think there's a few influences on my own thinking about that. One influence is, the fact that my own functioning as a kid was most disrupted by being diagnosed as having a severe learning disability, and that the effect of that diagnosis was just much more powerful than whatever this thing was that this guy who's written 3 books and has a PhD had or has, right? So the event itself, the social event of that injury, made me think differently about how we think and approach events of mind and mood and thought. And then I'm trained as a sociologist, so we're always looking for kind of the social elements um, within behavior. And so those things sort of came together on a public PAC team. And then the third thing is, what we did isn't anything new. This is exactly what they created. Programs that are oriented towards people integrating back in the world that they created at the point of deinstitutionalization, when they created community mental health programs. They've never been funded right, but their brilliance lies in how do you get people to recover socially, what's called psychosocial rehabilitation. That's just this model that's underappreciated, but it's actually what most people in this country get, not in the private sector, but most people are getting some poorly funded version of what they invented when they came up with community integration. So
Yeah.
all those things sort of came together in kind of my belief in the idea that even the most acute experiences can be treated outside of institutions, possibly, and that you're doing some good when you do that because you're protecting the person's social being.
Well, I know Sarah's visited Cooper East before,
Mhm.
a program that their second campus is licensed and open, was managing director for their campus, but it sits in the old Brower Hall, like the old psychiatric. It's renowned to have had
Mm.
or F. Scott Fitzgerald's wife
Yeah.
there, and she was one of the women who died in the fire and so on. So there's a lot of this history there, but they rebuilt this building out of the strongest fire brick that you can build, so you couldn't burn that building down if you tried now.
Mhm.
And if you go, having spent a lot of time there, the model that they used, and we're talking about back in the 60s, was this: you've got a hospital, and the hospital was connected to a wing that was a step down, and that was connected to a wing that was adjacent to an outpatient. And it was like there was a continuum of care located
Mhm.
on campus. And it's almost like the model that they came up with, like you're saying, Ross, was brilliant. And if we had embraced it thoroughly at the time, I don't think that would be in the space that we're in now, ultimately in community mental health circles. But the to kind of go and talk about Sarah's end of the world, which is, that's great that we get them out of the hospital. Maybe we get them through residential care and they get on the right meds and maybe they start getting a job and everything else. But then they turn 40 and 50 and 60 and 70. And you've got this long-term care. Dr. Stevens, you have these folks from a psychiatric standpoint or the psychiatry standpoint, and you're serving these individuals that have got decades worth of time on mixed levels of meds and trying to figure all that out. Walking into the world, you certainly cross through areas of care where it was probably done poorly and people, reacted poorly, or they fell off the map somewhere along the way. And you've landed in a care model that I really appreciate personally. But I think we need a lot more of. What brought you there? Like what was the epiphany moment for either one of you?
I mean, I'm just speaking for myself, now about 20 years of experience. I had good training. I'm very proud of that training, good experiences early on, but you start getting into the working world as a psychiatrist, and I've worked from inpatient, outpatient, and in between, things called day treatment, residential treatment, IOP, all these alphabet soups that we have, Todd. But you kind of realize that we have not built like a healthcare system as much as a crisis management system. It's not a recovery system, whether it's 10-minute med checks, revolving door hospitalizations. I mean, unfortunately, incarceration, which costs us billions of dollars a year, and yet doesn't change lives for the positive. You kind of see that the system is broken in terms of treating symptoms, but really not outcomes or futures. Talking about sociology with Ross. So sitting here with Ross and Sarah, two of my influences for years, you see, I mean, they'll call themselves different things. I'll use the term extended care. It's not acute care. And Lakewood Center and certainly Ellenhorn are very different, but what they were, and there's others out there, Gould Farm, which I had the pleasure of visiting. You mentioned other places. They really flipped the script on the warehousing of patients, or the revolving door, as I said. So they provide continuity, dignity, community, and recovery. We talked about the metabolic side, the nourishment, both in terms of food, activity, mental activity, physical activity. These are how they get better outcomes. And I've witnessed both at Ellenhorn and these other places where said they get better outcomes because it's a holistic approach. And it doesn't waste $60,000 a year incarcerating someone with severe and persistent mental illness or just shuttling them ERs, which just wastes tremendous care and doesn't serve the personal benefit of the patient or society's benefit whatsoever.
Completely agree. The other part that, the outcomes are better for these people, but it's also sustainable. When they land into an environment like you're talking about, you can keep it going.
As a young clinician, I would get, and I worked in community mental health and then private residential as well. One of the most heartbreaking notifications I would get is someone was being added back to my caseload who had already been on the caseload and who had been set up with an aftercare plan to move on. And they were either right back in jail or right back in the hospital or right back in the very same situation that brought them to me to begin with. And so when I first learned of Lakewood, especially for this population for serious and persistent mental illness, I was so ecstatically excited because it was like, this is what we're talking about. This is the way it can be for people. And I felt the same way, Ross, when I visited your Boston program. You had a group of, I don't know what you call your participants, but that were listening to a Talking Heads record. Like they're just sitting around talking about this record, hanging out on a sofa, chilling, which is what I do on the weekend, right? Like, and so they're safe, they're contained, they're on medications if that's right for them. There's harm reduction in place. And there's not this pressure cooker model of we got to go to 8 groups a day, you got to do this, you got to do this, and this burden of do all of this or you're going to be back in jail. And so that for me, from the clinical perspective, was there is a better way to give people an opportunity at a high quality and dignifying life that breaks them out of this cycle that's, as a society, we built for them. Like it's destined to fail otherwise in the current systems that we have in place.
Affordably. I mean, we talk about Lakewood Center specifically, and it's a nonprofit, but that's a pretty affordable rate. If you think about long-term care, what you're going to pay for a person who suffers from fairly significant, mental illness and conditions of that kind. And what would I do with that person if they're living in community, chasing after them in hospitals and prisons and things like that? And the cost of that, just like Dr. Stevens is talking about, versus, $5,000 to $7,000 a month over a year's time, you're going to spend incredible amounts of money less doing that care right.
State hospital in the state of Florida is $1,250 a day for state hospital. And that's where about 70% of our state budget for mental health goes to, is state hospital.
Ours is 25.
Yeah.
That's the billable rate. Well, and even Ellenhorn, which is, you know, and this is something that I run into with people all the time. It's like, well, that's really expensive. I'm like, no, it's not actually.
Mhm.
I mean, I think that for a person who is out in the world having to pay for what I would call adequate care, um, if, as Dr. Ross is saying, if these ACT teams were properly funded in the first place, if we had started,
Mhm.
if we had funded our model, the idea that we had in the beginning, and kept that going and made it, stuck with it and made it work, we'd see a very different world, I think, personally. But it also goes to you guys have created these programs, you've created them in environments where, either, people who can private pay for the care are coming in there with part of your clientele, or, as with Lakewood Center, there's a nonprofit attached to it. So there's funding that's supplementing some of the way the operations happen so that it can become affordable. Um, what do you think causes this whole thing to turn? Like, what
So,
is it? How can the models that people experience in the community, the ones that we're talking about that don't work, start to bridge? How do we bridge the gap and be like, hey, look over here, it works? Where do you think that turn happens?
well, most of the research says they work. I mean, most of the best practice research on how to organize and deliver care, which, by the way, is kind of better research on best practice than some technique, right? How is it actually delivered?
Right.
So how flexible is it? How in the home is it? How responsive is it? How much can it change depending on the person's symptoms while keeping the person within the same system? All those things. I mean, we have this crazy system where crisis teams are typically not connected to the treatment. Community mental health, the crisis team is part of the community mental health center, right? And so there's a complete fluidity to that. That those kind of models are really the most researched best practice models for long-term psychiatric events. But the problem is, we keep talking about is it cost efficient? It's not cost efficient. It costs a lot of money to care for people in a way that actually helps them recover. And it typically means a kind of revenue stream that isn't event focused. In other words, every session is where I make the money, because so much of it has to do with coordination, things that we can't bill insurance companies for. And so
Fortunately.
it should be this grant based thing that where, a community mental health center gets a certain amount of money, they're not reporting all their contacts, they're reporting, kind of recovery and stuff. And that's not cheap, but it's
Yeah.
what works, and it really is what they really can, brilliant ideas about how to make this work.
Well, and yours is a model where you're taking it to people where they live,
Yeah,
you're having to be out in the world with a form of containment that's mobile.
yeah,
Whereas Sarah's got this built community, it
yeah.
exists within the parameters of a place. What's the when you talk about, and I was mentioning this before, like the therapeutic use of community, and I think what Ross is also talking about here is it's hard to care for people in this way because you've got people who traditionally, as a symptom, isolate and disconnect, and what you're
Mhm.
bringing to them, even though sometimes it's professional and paid for, is connection. Um, you guys do that really well. We could talk about a shared case if we wanted to. Somebody who was not inclined to connect, and you really had to work to help him connect. But eventually he kind of accepted the invitation and warmed up a little bit. Dr. Stevens, you probably worked with this client before. How do you build that into an intentional community, as it were?
I, you build it, like Ross saying, not being event focused, especially in a potentially traumatic setting like an ER or an
Mhm.
interaction with police, or where, sometimes I think the idea of assertive community treatment, certainly psychiatric or PACT, we'll use that, is well-meaning, but I think in many places the actual rollout is Big Brother-ish,
Mhm.
where it's more protecting, or oddly enough, protecting the community from the client. So how does that, Todd, connect? How can you reconcile that with connection? I think where Ross is such a pioneer, and the other place we've copied his model. He let it be copied, just flat out. Or some of the people I work with, vetted and copied it for here in Texas. It's fundamentally different. The focus is on the patient, where the patient's at, and what the patient needs. And that personalization, I think, is starting to resonate, Todd. I think there's some awakening that, at least in mental health care, population management, and certainly in psychiatry, treatment algorithms leave too many people falling through the cracks. What I mean by that is, like, if you treat psychosis or schizophrenia like you would high blood pressure or cholesterol, it fundamentally leaves people uh, unwell, not connected, stigmatized in a way that's fundamentally different. So that's why that kind of approach, I think there is this now with the technology we're seeing, which is really advancing rapidly, allows the personalization of mental health care to reach those 6 million Americans who have severe and persistent mental illness, who will, on average, require 10 psychiatric hospitalizations in their lifetime. A third of those 6 million will have a period of homelessness, will have significant malnutrition, and are incredibly vulnerable. To me, the question is not whether we could afford to do this. It's that we can no longer afford to do the traditional way, which is colossally broken, as you've heard. So
Mhm.
I'm not sure it's either Lakewood or Ellenhorn's way. I think these are the early pioneers, the first kind of dawn on a realization that we need to do it this way to restore the dignity, to end the hospitalizations and the criminalization of mental health care problems. Because when it comes to things like psychosis, Todd, I think you're aware of this, high potency THC, what we saw after the isolation of COVID-19, the frankly too easy prescription of stimulants for people probably without ADHD, and all of that, and conferring in our youth, and the rates of psychosis, of hospitalizations for this are going up. And I think, we're going to have to face this sooner rather than later.
Yeah, I really appreciate that. I think that I think you're absolutely right. Like, our program is called a hospital without walls. There's nothing more terrifying than a hospital without walls, right? It's sort of police state, right? So it depends on how it's delivered. But I want to point out something about community, and also about how we sort of approach these psychiatric events. And I'm gonna make a big distinction between us four and the rest of the world who's mentally ill. And that is that us four, whenever there's a problem in our life, we can solve it immediately if we just find the right technique, right? It's just a piece of cake. You just say, like, I got to lose weight, and the next day you're losing weight, and it's just like that. It's easy. You have some sort of psychiatric thing bugging you, and you just go, well, if that technique works, then I'm fine. The rest of the world struggles with change. Change is hard for them. And the problem is the struggle over the change, not the technique. But we live in a system that's just offering them one mode of technique after the other, and calling them disengaged or in denial or anything when they don't accept it. In that group, the group that has a struggles with how to take in care, are the poorly treated group. They're called difficult to engage. And we need programs that actually work with them and aren't working necessarily on fixing the psychiatric issue, but fixing their struggle over change, their struggle of how am I going to make my life work. Those can go together. But if you don't take care of that problem of metabolizing help, bringing it into your life and doing something with it, you can't get to the other. And you can't get to community that way either. That's what the loneliness epidemic's proving, is that loneliness is mobile. That until you build a sense of your own value and your own worth to people, you'll stay lonely. And so just giving somebody a community doesn't make the thing happen. It's pride that makes it happen. It's sense that I'm worth being in this community that makes it happen. And so all of these things we talk about sort of delivering, instead of how do we get the person to that place where they actually can engage in that way. And that's really the poorly treated group. They're just completely neglected in ways. They're just told, like, if you can't show up to this clinic, you can't do this and that, something's wrong with you because we've got the perfect solution for you.
Well, it's reflected by how my practice works. Most of my clients are not the person who needs the care. They're a person who's the parent or the associate, like, I'm working for them, helping them help that person realize they need care, get to it, and find their way through to a better, more independent life. And that's where that's indicated. I'm sorry, Sarah, go ahead.
I was just going to say, Ross, you're like bringing to mind a term that I really don't like to use, which is treatment resistant. And we throw that around a lot as clinicians of, well, Johnny's treatment resistant. Well, Johnny can't sit in group 6 hours a day. Like, and Johnny doesn't understand the medication that you're presenting to him. We have clinicians who, I've been, I mean, I'll go if the person's mad at their clinician and they have an appointment with Dr. Stevens at 2 o'clock. He was here the other day and one of them just stopped me in the middle of the hall and I'm really mad at her today. Can you go to my psych appointment with me? But we go with them so that we can advocate for them and help them to identify what's being said to them, and be that extra voice in the room if that's necessary. But it's also not a requirement. There's people who, I don't want anybody in my psych appointment, and so they go on their own. But I think, one of my favorite swag items that I've gotten, Ross, is Aaron for Christmas sent me a bag that says meet people where they are. My team hated that I got that for Christmas because there's signs everywhere all over Lakewood that says meet people where they are.
Mhm.
And I point to them quite a lot when my team will want to be like, oh, but the rules are, and I'm like, nope, we got to meet people where they are. And so your bag was a pretty funny joke around Lakewood for a few days because I carried it everywhere I went. But I think it's meeting people where they are. It's putting a garden in if somebody won't come out of their room, but we know that they like to work in a community garden. We've done those things, and I've seen programs like Ellenhorn get really creative with that too. And it's okay. Well, we're just going to come to you until you're ready to come to us, if you're ever ready to come to us, right? Like, I think removing that boundary and that pressure of what a positive outcome looks like is really important in these care models and in these conversations as well. Is we have one client who's here right now who had over 125 hospitalizations in a 2-year time period. And John and I were talking last night, and I'm going to knock on something, but I mean, he's been here 2 years and hasn't required much of anything in terms of emergency urgent support. But there's also been a lot of unlearning for his family that, yeah, he's probably not going to use that bachelor's degree that he went and got. We're proud of him for having that, but for right now, he hasn't been in the hospital in 2 years, and we haven't had to, he also hasn't taken off on foot. He's happy to be here. He's found a community. He's found purpose. To your point, Ross, it's finding that purpose and that reason for existing in a community to get someone to engage in it to begin with.
Yeah, I mean, a person says to you, you're a treater, and the person says to you, I don't know if I want to take that pill. I don't really know if that's going to, I've got to look into that. I don't know. I've taken medications before. I don't know if I really want to do that. Or a person says, okay, I'll take the pill. Give me the pill. Give it to me right now. I don't even want to know anything about it. I just give it to me. I'll put it in my mouth and I'll take it. That's a non-treatment resistant client. It seems a much less sane version of how to approach medical care.
Yeah.
And I
Just
don't
give me
know
some medicine.
about
I'll put it in
this.
my mouth.
Yeah, I mean, I don't know about this. I want to make sure this is going to work this time. It's the logical consumer approach that can get illogical and get kind of crazy, but it leans much more towards sanity than just pop it in my mouth and take it, right? But John, you're looking for collaborations, right? You're looking for collaborations. It's the collaborative event. Is the event.
Collaborative, and I'm pro medicine. Everyone, you guys know that. And when it comes to psychosis, antipsychotics are necessary for the
They're a
large
miracle. They are.
Yeah.
They're necessary, but they're
I
not
disagree on that,
Okay.
but
we'll go there.
you gotta, you're gonna have some sparks. We have different, but I think we all hear antipsychotics quiet the voices. They help melt away the delusions or the paranoia, but they don't rebuild a life. And that's what we're all talking about here is, to me, medicines are foundational, but these versions of extended care, they're not new. These have been around, but both people you're talking about represent, what people have been doing things away for a long time. But to me, the foundations are structure, community, therapies. that's the house we build on, that foundation of medicine. I think it has to be there. I know that sometimes there's the rare case, you know, whether 1 out of 10, probably closer to 1 out of 100 that could be off medicines and do well functionally and achieve goals, but the large majority, it's not either or, it's both and.
Mhm.
Well, and I'll give Dr. Ellenhorn here a little credit. He's like, I don't know about this miracle thing, Todd. If a person walks into a hospital or walks into a facility of any kind, and what they're having is psychosis, and they're hearing voices, and they're having hallucinations and everything else, and you give them a medication, and those things dissipate and even go away, that feels like a miracle. Now, kind of the way the medical profession approaches things, like we've already said, is like, great, problem solved. And it is overused. It is seen as the kind of the only medium of care in a lot of emergency settings. Like, great, they're no longer a danger to themselves or others. You can hit the street, just take this medication, and it's not a miracle then. What it is a management issue, and it makes the patient feel horrible, and there's lots of long-term side effects, and there's all these other things that are complicated about it. And again, for I run into a lot of people, and medications are going to be one of the mediums of care that they need to achieve a sustainable recovery. That's true. At least for now it is.
Mhm.
It's not the only way. Like say, if people can pay for it, sometimes they can find another way. The number of people who suffer from these conditions who've been able to stay off of medications and manage it through diet and exercise and everything else, they are very few number of
Right.
people. And they are some of the most dedicated and disciplined people I've ever met in my life. But it's been done. So to kind of go to this, and you work with folks, Dr. Stevens, who suffer from obesity, and you're engaged in that level of medicine. Dr. Ross is also, the metabolic psychiatry. And we all know that people on a lot of these long-term psychiatric medications, they experience metabolic syndrome. They get
Yeah.
very unhealthy, or they gain a lot of weight, have problems with the sun, and vitamin D deficiencies, the whole 9 yards. It's like there are all these complications and issues. And then there's also the other side of it is like, can we manage some of this without this heavy medication, but actually engaging in some kind of dietary practice or exercise or any of these other pieces that are lifestyle based? So it emergency medicine doesn't have the time, right? They don't have that time
No.
to assess any of this stuff, to look at it. I need to get them in, I need to get them out. I got beds that there's people lined up at the door. We need to keep this thing rolling. Where's the bridge? Like, where's the bridge for obviously seeing one of you or coming to a program that features these kinds of practices is one way, but where's the bridge for the average person who's maybe suffering from a condition, or family with a family member that's suffering a condition, to find their way towards this kind of better model of care when it comes to what you put in your body? Where's the bridge to that,
I think
do you
that
think?
you said it a lot there, but that would be news to most people. Most people or families do not have all those elements in place, like you just went through. The week or two, the crisis intervention, the event, as Ross said earlier, a week or two in the hospital might help you survive that event, but you're not going to thrive. I think 6 months in any of these programs we're talking about, that's how you thrive. That's what I've seen. I've had my own patients from my private practice.
Time.
I've seen countless times that it's the consistency, it's the implementation of all those things. In these fragmented models, you don't get all those things. So what you just said, cut, paste that, there's your Reels clip. That is news that most families, when they look at, it's not, they don't have the prescriber that's listening. They don't have the therapist. They don't have the community. They don't have the support. They have far too much stigma. They have insurance that's not covering this or that. And certainly don't have the majority don't have the exercise, lifestyle, and nutritional interventions. And that's why people with severe and persistent mental illness, depending on year, die 8 to 10 years sooner. Most of the time, not from suicide or interactions with the police. They die from boring things like heart disease and stroke and diabetes.
Yeah, I mean, I think that if you were to study the physiological effects of what are called social resources, psychosocial resources, when you don't have them, you would see these same physiological responses independent of what you put in your mouth because of cortisol, because these are called stress buffers, essential social support, sense of purpose, self-efficacy, self-esteem, a sense of your value in the community. Without those things, social psychology is really proven. You go straight into a stress mode and a chronic one. And we're focused on metabolic stuff, which is awesome. It's great. I believe in it. But we're doing it again. We're not looking at the social experience of these people because our brains just move towards the body, into the physique and all those sorts of things. When I believe that the underlying thing that's killing them is years of stress because they don't have these resources. You cannot survive a life if you don't. This is what the loneliness epidemic is showing us on some level. You cannot survive. Loneliness is ties with cholesterol and smoking for heart disease because of the cortisol. You're talking about lonely lives. You're talking about lives, even if they're in a program, even if they're not isolated, where they don't have the sense of value and pride to make them feel like they belong. And so not belongingness is a killer. And maybe it's not the only thing. It's the meds, it's the metabolism, it's all those sorts of things, but we keep extracting it as the most obvious killer in all this. We'll give it to ourselves. We'll talk about the loneliness epidemic affecting non-mentally ill clients, but we don't give it to the most lonely people, which is the mentally ill clients, and allow them to be also part of this idea that it's a killer, that it's a danger, it's an epidemic, you know?
But it's addressable. Sarah, I mean, you want to talk about you. Sometimes I feel like you're an events coordinator there for all the events that you do.
Yeah.
I'm going to let you talk about that. How to combat
Yeah.
loneliness.
So one of the things that comes to mind here when we're talking about medications or any of this, any of these things, any of our programs offer, is I think one of the bridges, Todd, kind of circling back to your question, is that dignity and autonomy is one of the most important pieces. And I have had to seek out care for a loved one, and if I said to him, hey, you didn't take your medication today, so now you have to discharge and go home, or you didn't do this thing, so now we're going to remove care and support from you, that never made sense to me. But rather, as a clinician, taking that responsibility of, okay, this person's not engaging, this person is, then it's finding out what Ross just said. Okay, this is a loneliness issue, this is a social support issue, this is a person not having opportunity to engage in a way that they feel safe and comfortable. So I mean, I could just speak for Lakewood alone. We find ways. They went to SeaWorld yesterday. That wasn't for everyone, but it was for about 8 people, right? And they went and they came back and they told me what a great time they had at SeaWorld. But here on campus, we also made bracelets. And we made bracelets because this one particular resident had a bracelet making kit and was, Sarah, do you want to make bracelets with us? And I had everything in the world to do yesterday except time to make a bracelet, but I sat down on the sidewalk with them and made a bracelet because that was, they engaged me, they probed me for, I'd like some connection and you're who I'd like the connection with. So I think it's comes back down to being able to get creative and being able to find opportunity for people to combat that loneliness, which is easy to do in a program like mine, or a program in general, like Ellen Horn. I mean, I don't want to say it's easy, but to Ross's point, that costs money. It's not cheap. Um, we have to pay people a livable wage. We have to have resources and supplies and things like that. But in the community, in terms of that, it is the point. I think
Alternative's
that
not
is where
cheaper.
it's no, it's
Mhm.
definitely not. I mean, inpatient hospitalization, unemployment costs us all money. All of these things cost society money. So being able to plug in that loneliness element and find connection for people. But I think a lot of that comes down to acceptance. With my late brother, when we finally accepted what he was willing to receive in terms of care and support, he started to accept the care and support. But when we're forcing on someone, when you're telling someone what they need and being prescriptive with things, Um, I like to say that everything's optional here as long as we can keep you safe. When we have we have person who is not on an antipsychotic, and I think he might be that one of 100 that John's talking about, but he has suffering, but he also has support and choice. And I think that piece is really important when we start bridging things. But when the legislation that's passed is if you're homeless or mentally ill, you're going to jail or the hospital, well, who's going to reach out then? Like, why would I reach out if jail or psychiatric incarceration are my two options?
And I think that the piece about this is like, okay, where does this problem begin? Does it begin in isolation? Does it begin with stigma? Because they can't find community, and isolation becomes the natural thing that they do. But what I notice a lot for folks that we work with is that, and I said this the other day in a presentation I was doing with a local bar, and I said, they were like, what do you do with a person who might need some care, but is not really willing to accept it, but they're a professional and they're working and all this other thing? I was like, well, it's very difficult to realize that you need help when you need help. And it's not something that people will often readily accept. There's a like, nope, it's fine, put it over here. But I also think that the stigma and all the other things, what I see with the clients that we serve is this has gone on way too long. It's gotten so bad because it didn't get attention way back there when it could have, when, more socialization and some good therapy and possibly some dietary approaches and some of these other things, which at that moment would not have been that expensive, could have had an impact, and that person wouldn't have reached a level of acuity in their condition that required all these major interventive strategies to get them to a place of wellness. And so, maybe it's a thing of education to the community as a whole. It's like, look, there are several medical conditions we could pull out where it's like, hey, do this early, brush your teeth,
Mhm.
eat greens. Like the education is like, don't think of mental distress as something you shouldn't address. Think of it as something that's as critical to your health as anything else.
Yeah, I mean, I think that some good stuff's being done about first break psychosis right now, where they're thinking more and more about on the unit trying to figure out how to keep the person in school or work,
Mm,
and how to get them back to their social role as much as possible. To me, that's preventative medicine.
yeah.
You
Are you
know,
seeing that in New York or down in South
yeah,
Carolina?
it's a big deal in New York right now,
Yeah.
and I think that kind of model. But there's other places too where they really kind of think about this thing at the point of crisis. This is how do we kind of keep that stress buffer around you as much as possible, and that puts a buffer to an extreme event for the person too. Because the worst place for a person who's psychotic to be is an emergency room for 48 hours on a stretcher with their hands bound, and then on a unit. That's the worst moment for someone in the middle of psychosis. And so it's also trying to kind of think about that and how do we kind of soothe that element too. And so there is some good work in that area as far as how to kind of create those buffers, you know?
Yeah.
But we
I
still
would,
don't have a center of excellence for that. And that's something on
Yeah.
for psychosis. You see
Yeah.
now
Yeah.
for obviously here in Houston, MD Anderson, a center of excellence for
Yeah.
cancer. You
Yeah.
see places for autism. You even have some small programs for mood disorders or OCD or eating disorders. How many treatment centers, and Todd could probably tell us, do you have for substance use disorders, ranging from the usual 30-day or the
Mm-hmm.
luxury
I can't tell you,
Malibu?
there's too many.
Tell me, though, a place where you could go for first break psychosis to truly, for diagnosis, for vocational, for again, to involve family, to have realistic expectations, to maybe get a waiver from college so it's not just all Fs or a medical withdrawal. I mean, it sounds so basic,
Mm-hmm.
yet there are really no either funding mechanisms or I
Mm-hmm.
think the will. There's no walk is walk for breast cancer and autism awareness. Where's the schizophrenia walk? It's just
So Dr.
Yeah.
Stevens is starting a nonprofit for one.
you have any idea, but I really
Let me
it's
We're going to be walking this time next year for schizophrenia. John's
just not in
organization got
Houston,
it.
Florida in the summer.
I
let me
mean,
talk a little bit.
We go to New York.
Let me
Okay.
talk a little bit about this model that we use the technique from it, but not the model necessarily. Called Open Dialogue from Finland, and this hospital called Keraputis Hospital in Finland. The town around it, the psychosis, the experience of psychosis has dropped. The functioning, if you're psychotic, has gone way up, right? So even if they're psychotic, they're able to kind of get on with life on some level. And when you call there in crisis, I don't know how they do this because it could never be done in the United States. Whoever answers the phone becomes your case manager. Basically, your care begins the minute you call in. And now that place is following you from beginning to end to the point when you don't need them anymore. It's
basically,
not like you're coming
you
in.
get a therapeutic consultant the moment you call.
You get a team because they start doing this process called open dialogue too. This way of saying your treatment doesn't begin after in the hospital, or it's not segmented in the acute phase and then the next phase. Your treatment begins now. It starts now, and we'll figure it out with you. And all treatment planning is a therapeutic event. It's not a bureaucratic event where we meet without the person in another room and decide what they need. It's a conversation that begins the minute they walk through that door with their family, typically, with the network that's been affected. And their model says that the best medication at that point isn't an antipsychotic, but possibly a benzo. You're just calming the person down because psychosis is kind of this stressful event, this stress-created event of isolation, because they want to actually hear what's going on for the person on some level. And then they might introduce antipsychotics. It's not like they don't do them at all. But the point is how do we kind of create this continuity of care from beginning to end? And John, what you're describing is exactly right. Because these things are siloed, crisis events are siloed, the treatment just gets disorganized, in a way where it doesn't match what this disorder needs, which is this a lot of continuity.
And it's crazy making the fragmentation.
Yeah, exactly. It's crazy making. So much of psychosis is iatrogenic. It is created by systems that give people the opposite of what they need when they're in psychosis. It creates stress and it creates isolation, which are the two main non-biological triggers of psychosis. It's insane that we have a system that does that. Yeah.
Well, and that's kind of our, as a consultant, our continuity of care is our biggest role.
Yeah,
it's like
that's right.
We're drawing the line between, it's like, okay, they've ended up in the hospital. This is not where the care happens. Let's get them in. And one of the biggest hurdles that I ever have to cross or jump is this person having been in models of care in the past, deciding that that's the only model there is out there, and they don't want to go do that again because it sucks. So I'm coming in here going, hey, why don't you consider this place? It's like, well, it's all the same, isn't it? It's like, it's actually not. I'm sorry that you've had the experience that you've had, but there are places that actually care about you. You're probably going to feel valued and like you have a community and connection. Let's give it a shot, shall we? Like, that's one of the biggest things I have to talk people into. And I don't blame them for being resistant to it, quote unquote. There's that word again, right? But, I think that we've formed now the board for this nonprofit that Dr. Stevens is starting.
We just need the donor or the donor.
Right. There's probably some. We probably got some traction out there. We could get something together. We've already got a nonprofit. I mean, we got sitting right there, right? But I think that there's I tell people all the time, we actually know how to do pretty good mental health care. We actually do. It exists. It's out there. We've got people who are dedicated to doing it. We're providing it for some. If we could put it in places where it was accessible to everybody, we'd see a whole kind of different world. And I'm really grateful to this group as people who are pioneering what that idea actually means. So, we could spend probably hours just talking about this. I know that I could for certain, especially with this group of star-studded professionals in the field. Thank you all for being here with me today. Dr. Ross Ellenhorn, Dr. John Stevens, and Sarah Summey, thank you for being who you are in the world and helping us, provide something like community and care for the folks who really need it. This has been Head Inside Mental Health with Todd Weatherly. We'll be with you next time. Thanks, guys, very much.
Thank you.
Thank you. Great.
I feel so lonely and lost in here. I need to find my way home. I feel so lonely and lost in here. I need to find my way home. Find my way home.